Good morning. I understand there's a big traffic tie-up because of another person getting hit out here. So we probably will see people walking in. Anyway, we're really lucky this morning to have Dr. Kevin Frick present to the Center for Clinical Trials seminar. He's a health economist. Probably most people here know him because he has long-standing relationships within the center. Kevin is, as I said, a health economist. He's a professor in the Department of Health Policy and Management here at the School of Public Health. He trained in economics and health services research at the University of Michigan after completing his undergraduate studies at Health Policy Administration at Penn State. He's associate chair for academic programs in the Department of Health Policy and Management, and he's president right now for the Faculty Senate of the school. Dr. Frick has taught numerous courses on cost and cost effectiveness from the beginning of his career here at the school. Maybe some of you have taken his courses. He's published numerous studies related to methodology for such studies in journals of interest to nurses and specialists in eye care especially. He's also advised our students who are working with us, and of course other students as well, many other students. He served for 4 years on the National Advisory Council for Nursing Research, where he helped to organize a number of workshops. A number of the cost-effectiveness studies that Dr. Frick's worked on have been tied to randomized trials, and specifically projects ongoing in the Center for Clinical Trials. This provides him with a particular set of insights on the relationship between economic studies and randomized trials, and this morning we're going to hear about a specific case, incremental cost-effectiveness of Fluocinolone Acetonide implant versus systematic therapy for non-infectious intermediate posterior and panuveitis. And this is the MUST trial. Thank you.
Thank you very much. So an outline, I want to begin with some cost-effectiveness terminology, make sure we're all on the same page with some basic terms and why we would be thinking about measuring some of the things that we are challenged to measure sometimes in randomized trials. Then a little bit of background on the study, basic 2-year effectiveness results, then the 2-year cost effectiveness results, actually the 3-year cost effectiveness results, some newer 3-year quality adjusted life year results, and then some challenges that we faced along the way. And I'm going to focus mostly on the very first section, the cost effectiveness results, in the very last section, with the other section just to provide some context for the remainder of the presentation. Because I think one of the most interesting things, while the results of the study are interesting, don't get me wrong, I think for thinking about how this relates to the Center for Clinical Trials, I think one of the most interesting things to think about is what are the challenges that we face when we try to link a cost-effectiveness study to a planned randomized controlled trial. So when we talk about cost effectiveness, one of the first terms that we hear or that we read when we read the literature is incremental. We see this terminology, incremental cost effectiveness ratios. And it's useful to understand exactly what that means. We're comparing the extra costs that are needed to obtain extra outcomes when one alternative is more expensive and more effective than the other. One therapeutic choice is more expensive and more effective. It could be therapeutic, it could be prevention, it could be a variety of things. And so again, we see this term incremental cost effectiveness ratio. And I like to compare it to a unit price. How much does it cost us to buy more health? It's not a way that everybody likes thinking of it, because that means we really have to think about, well, what's it worth paying to buy more health? And sometimes we say, well, health is such a great thing, we should be willing to pay almost anything to buy health and save lives. Well, in theory, that's great, but we have limited resources. And so that's what this tool helps us to get at. And so in the example with the MUST trial, we could look at the expense per person with improvement in visual acuity achieved, or percentage of the patients with improvement in visual acuity achieved. And that would be classified as sort of a traditional cost-effectiveness analysis, where we have outcomes that are mostly clinical in our denominator, our cost per percentage change in people with improvements in visual acuity. And this is a graphical example just to help us sort of wrap our brains around it. You can see that there's the cost on the vertical axis, and then percent of patients with visual acuity improvement on the horizontal axis. I've labeled them A and B just to sort of give us something to work with. You can see in this example, B is both more costly and has a higher percentage of patients with visual acuity improvement, which then means that we can calculate a ratio, and the slope of the line, when you draw a line segment like that, actually tells you what the ratio would be. So that's just, again, helping us to see graphically what we talk about and what we read about in the literature, which is sometimes accompanied by a graph, but not always. Sometimes we see the term dominance. It's how we refer to a situation when one of the alternatives is more effective and less expensive. And in that case, it's a simple economic question, because it doesn't take somebody with a PhD in economics to tell you if one alternative is more effective and less expensive, that economically it's the better choice. Okay, the key question is that economics doesn't always help us to get at things like ethical issues or distributional issues. And while the economic question may be very simple, there may be other things to consider in the decision-making process that wouldn't lead to quite such a simple decision in all cases. And then again, this is just a graphical example of dominance. In this case, alternative D costs less and brings about a greater percentage of patients with improvement in visual acuity, and we would say that D dominates C in this case. We do see this in some studies. Sometimes more effective things save enough money later on, or are simply less costly to begin with, that they do have a lower cost when we look at it over a long time frame. One other type of study that we see is called cost minimization. Studies don't often start out as cost minimization studies. They usually start out as cost effectiveness studies because we think that one of the two alternatives will be more effective and more expensive. It turns out that the two alternatives are equally effective, and then all we have to ask is which one costs less. Again, a very simple economic question, although there may be other ethical and distributional considerations. The key is, what do we mean by the same outcome? And the MUST study is a great example of having to clarify exactly what we mean by the same outcome. So maybe they have the same percentage of people who are improving in visual acuity, or maybe they have the same average improvement in visual acuity, but there's a very big difference in the side effect profile between something that gets implanted in the eye and systemic therapy. And so do we, even if the main outcome is the same, do we really want to say they are the same if their side effect profile is entirely different? And I would suggest the answer to that is no, but that's something that we have to think about when we're thinking about describing a study and reporting a study as a cost minimization study. And again, just to emphasize graphically here, E and F have exactly the same percentage of patients with visual acuity improvement based on the way it's graphed, but E clearly costs more. So from a purely economic perspective, we would choose alternative F if these two were the options available to us. We also see the term cost-utility analysis. Instead of focusing on any outcome in general, like level of improvement in visual acuity or percentage of patients with improvement in visual acuity, we use the outcome called quality-adjusted life years. They are a measure that combines different aspects of morbidity and mortality into a single measure. That can be very useful, okay? When we're talking about treating uveitis using obviously either an implant or a systemic therapy, there might be different aspects of quality of life that are affected by the alternative therapies. And so we might want to make sure that we have an instrument to capture those multiple possible effects. And there are a variety of quality of life instruments that may allow us to do that. We don't have much of an issue with mortality when it comes to uveitis, but there are plenty of conditions where there could be multiple types of impacts on morbidity as well as an impact on mortality, and it's useful to have a single measure that combines all of those. So this is a graph that shows how we calculate qualities at a very simple sort of starting point level. It's an area under the curve measure. On the horizontal axis, we have time, usually in years, given that we're talking about quality-adjusted life years. On the vertical axis, we have a scale that's a health utility scale. Health utility is a particular way of measuring health-related quality of life. On the scale for health utility, 0 is death. There are some measures of health utility that allow for states worse than death. As I always like to point out, we wouldn't have a debate about assisted suicide if there weren't at least some people who thought that some health states were worse than death. But at the individual level, it's almost a philosophical question whether each of us thinks there are health states that might be worse than death. And then 1, it's usually described as perfect health. In the course of this study, I've tried to call it no problems rather than perfect health. Because, as I will mention when we talk about our actual measures later on, if you qualified to be eligible to be in the MUST study, obviously you had uveitis at a level that you were, willing to accept randomization to where you get something implanted in your eye. That suggests to me that there is a problem with your health, if you're willing to accept that randomization. The particular health utility instrument that we used, we had a surprising number of people who answered that they had no problems based on the 5 questions in this instrument. And so I've taken to calling it no problems rather than perfect health, just to emphasize the fact that there's clearly a distinction between saying I don't have any problems on this particular survey instrument and being in truly perfect health. How do we gain quality adjusted life years, since that's an obvious goal, or preventing the loss of quality adjusted life years? We can gain qualities by improving health-related quality of life, specifically this measure called health utility, while alive, or by extending life. And as I mentioned earlier, most of the gain that we would expect to see with respect to uveitis, or perhaps even all of the gain that we would expect to see, would be improvement in quality of life while they're alive anyway, not changes in mortality necessarily. Measuring health utility, there are some studies where we ask individuals how they feel about their health state, and there's a complex series of questions that they get asked about trade-offs that they're willing to make. Given the burden of other things that we usually have going on in randomized trials, we don't generally ask each patient or each study subject in a randomized trial to go through this complex series of questions to rate their own health state. Instead, there are a variety of instruments that are available. We use one called the Euroqual in this particular study that are pre-existing instruments. They ask a number of questions ranging as low as 5, as many as 8 to 12 and some standard instruments, and then there are some other instruments like the SF36, which wasn't originally designed as a health utility instrument but has been adapted for use that way. But it's a pre-existing instrument with a pre-existing scoring algorithm, so we can look at a person's responses to the questions and assign a health utility based on those responses. And again, these instruments generally then only take between 1 minute and maybe as much as 5 minutes, rather than having to ask what is always a cognitively demanding series of questions if we're trying to ask people to give trade-offs about their own health state. Ratios with qualities, we're looking at the extra dollars spent per quality adjusted life year gained. So in terms of a unit price, if we think about unit prices in our daily lives, we go to the grocery store and we know about what we expect to pay for a half a gallon of milk, a carton of ice cream, a dozen eggs. If we're thinking about unit prices for health improvement, we're essentially we're asking ourselves, what is it worth to spend to bring about health improvements? Or what is it worth to spend to buy a quality at the population level? There is no formal level assigned by the government. In fact, under the Affordable Care Act, we're not even allowed to use qualities for healthcare resource allocation decisions. But if we were, we might want to have an idea of what is considered worthwhile. And so the number that has been used most frequently since the 1980s, and there's some debate as to whether it should be updated, but the number that's been used most frequently is $50,000 for each quality adjusted life year gained. Also commonly used, $100,000 for each quality adjusted life year gained. I'm showing the U.S. GDP per capita down here, which is about $50,000, only because the World Bank at one point made a recommendation of looking at dollars per disability adjusted life year change rather than quality adjusted life year. And the two concepts are vaguely similar. And they recommended using 1 times the GDP per capita as sort of your base for comparison. And if it costs less than 1 times the GDP per capita to have an improvement in health, then that was considered a very worthwhile investment. Okay? And so that's how we use it. We could then recommend it to policymakers or to people who are setting guidelines in terms of trying to help them make better decisions, taking into account cost issues as well as effectiveness issues. Measuring cost, if you're going to think about doing this alongside a randomized trial, you want to think about the cost of the initial or index treatment, particularly when we're looking at therapeutic studies. In this particular example, you have the implant versus the systemic therapy. In another study that I'd been involved with over time, looking at dysfunctional uterine bleeding, we were comparing hysterectomy with a much less invasive procedure. And so we want to capture the initial therapy as well as the ongoing management. And even if one of the alternatives has a much higher cost of the initial treatment, the ongoing management might be much higher cost for the alternative. And the key question then is, over what period of time, if ever, do those two even out? That's an interesting question that we can answer with a study like this. When we're planning for it, we have to consider, where are the data going to come from and how much detail do we want? Is it a situation where, in full compliance with human subjects issues and HIPAA issues, you could possibly get actual billing records? Okay, is it a situation where you could actually get medical records? Is it a situation where the best you can do is have part of a survey instrument at each follow-up where you're asking, what drugs are you on? Are they still the same ones you had last time? What other contacts with the medical care system have you had? And then how do you ask people to describe it? Do you just want to know that they're on the drug? Can you possibly ask them to give you information on strength and dosage and frequency? What about compliance versus non-compliance? If they know what the strength, dose, and frequency they're supposed to take it at is, but they don't necessarily take it at that frequency as planned. There's all sorts of details that at the end of the day, you're probably not going to be able to measure very accurately. And that was one of the challenges that we faced. And one of the things we had to decide, how are we going to use these data? When you get around to writing up a study, usually it's been a couple years since the beginning of the study. So if we're reporting something in 2012 or 2013, which we hope to get the must results out in 2013, people don't care what the treatment cost back in 2008. People want to know what the treatment cost in 2013. So we're going to need to make some inflation adjustments. And there's a variety of different ways that we might make inflation adjustments. And then we also have to consider how long. Okay, are we only interested in designing a cost-effectiveness study that covers how long we followed them in the trial, which could be interesting, but maybe not the whole story? Are we interested in trying to project it out for the expected functionality of one of the eye implants in this particular case, and then sort of say, okay, if as long as that eye implant lasts, this is what it would cost, then you have to do it again? Or are we interested in trying to make projections over a lifetime for the individual as best we can, given the combination of the data from the randomized trial, and then anything else that we can find from other studies where we could build a long-term mathematical epidemiological model to describe the long-term lifetime impacts of the different forms of treatment? And lots of people try to do the last of those three, but there are some conditions and some forms of treatment for which it's very difficult to build up a model that goes beyond the duration of the follow-up in the actual randomized trial, or at least much further than that. And so these are the types of things that we need to think about as we're thinking about costs. The ultimate objective, as I mentioned or referred to a little bit earlier, is to provide policymakers with an idea of what should be covered. We could provide guideline developers with an idea of what should be recommended. Most people who talk about doing cost-effectiveness studies like to emphasize the fact that these are intended to be at the population policy setting level. But once there is policy establishing this is covered and this is covered, the bedside decisions may certainly depend on what the patient can afford, okay? But the bedside decisions should not be dictated by population-level cost-effectiveness results. We should leave those aside and make the best clinical decision for the patient in light of what's covered or what's recommended, which may have been based earlier then on cost-effectiveness studies. So it's not necessarily, again, to dictate every bedside decision, but at a 30,000-foot policy level. Okay, a little bit of background on the study itself. And again, I'm going to sort of skip over lots of the details, but just sort of give you a flavor of the background of the study so that we can get to the cost-effectiveness results, how we interpret those cost-effectiveness results, and then a few more notes about the challenges. And some of my colleagues on the study are in the room, and if they want to elaborate on the challenges as we get to them, they can certainly chime in as well. So uveitis refers to approximately 30 different diseases characterized by intraocular inflammation. You can see a little bit of other data about the epidemiology here, the 5th or 6th leading cause of blindness, and you can see the incidence and prevalence estimates. What's interesting from a cost-effectiveness point of view is that many of the other eye diseases that are leading causes of blindness affect older adults, which has a particular impact when we're looking at quality-adjusted life year measurement. They have fewer years over which to enjoy the gains in quality of life, And if we're really concentrating on the gains just from vision, think about a multi-comorbid older adult who maybe has 5 comorbid conditions. Maybe they got diabetes and COPD and angina and arthritis, and they have some age-related macular degeneration. Well, if you can restore part of their sight or prevent any further vision loss using Lucentis or Avastin to treat the age-related macular degeneration, how are you going to change their quality of life if they still have all those other 4 conditions? Okay, is it going to be as big of a change in quality of life as restoring vision to a 22-year-old, or is it going to be a much smaller change because there are so many other things that are having a negative impact on their quality of life that certainly there's something to be gained from preventing further vision loss or restoring vision if it can be restored, but the gain is not going to be as big. So in terms of the potential quality of life impact for younger adults who may have no other health problems and the number of years of quality of life impact, uveitis is likely to have a bigger effect on changes in qualities than treatment of many other eye conditions. This is just a few other details, understanding sort of the indications for immunosuppression. Description of the systemic treatment. Again, I don't want to go into a lot of the details here, but it's important to recognize that the systemic treatment has side effects, and that is something that from a quality of life point of view, we are interested in how those side effects might affect a person's quality of life and incorporating that then into the quality adjusted life year measurement. This is an example of showing the size of the implant in comparison to other items that we are familiar with. Few facts and figures about the implant itself, and recognizing that the implant costs somewhere in the order of $19,000 or $20,000 for each implant. Again, it has a big impact on the costs. The unanswered questions leading into the study were the comparative effectiveness of the implant versus what's referred to as standard systemic treatment, the role of the implant as initial therapy, as opposed to waiting to see whether the person responds well to systemic treatment, long-term effect on visual acuity of both treatment approaches, and then the different side effect profiles, the impact on quality of life, and then ultimately tying that quality of life impact to the cost effectiveness analysis. This is just a focus on the specific aims, and the key here is that comparing cost effectiveness was in fact one of the specific aims going into the study, and so we wanted to make sure that we had as much data and as high quality data and as high quality a procedure for taking the data that we were able to collect with sometimes rather vague amounts of detail about procedures and about pharmaceutical products that people were taking, and come up with a standard procedure for translating that into an actual quantity of the product and getting a price of the product or quantities of different procedures and getting prices for those procedures so that we could create a credible cost effectiveness estimate. And again, emphasizing that in many studies, it is simply impossible, particularly in a multi-center study with centers ranging across multiple states, and in this case, even across multiple countries, it is virtually impossible to get meaningful billing or reimbursement information from all of the centers. And so we had to come up with a way that we could get quantity data and find price data in order to calculate our cost in a way that would be analogous across all of the centers in this multi-center trial. Few more facts about the design. Multi-center randomized trial, 1-to-1 randomization, randomization stratified by the location of the uveitis, and randomized by patient. Few facts about the eligibility criteria, just to sort of get an idea of what some of the characteristics of the patients might be. The implant therapy, a few details there, again, just to have some background for this, and then replace the implant when the uveitis reactivates. Clearly, given what I told you earlier about the cost of the implant, replacing it is going to have a really big impact on the cost for the cost effectiveness analysis. And so one of the keys when you have something that may need to be repeated is understanding the frequency with which it needs to be repeated and understanding the cost implications of the repeated procedure. A few more facts about the systemic therapy. Again, there's a standardized approach to using each of the agents and monitoring for side effects, again, with the side effects having potentially important impacts on quality of life. And then a few other things about the indications for immunosuppression in the systemic therapy, and our list of outcomes. Again, one of the things about this list of outcomes is that you see is it's quite a long list. If we were trying to do a cost-effectiveness study where the effectiveness had to be measured in a single outcome, we could look at changes in best-corrected visual acuity. We could look at uveitis control, or months of active uveitis experience, trying to have fewer of those months. But one of the nice things about a measure like quality of life is that as long as you can find an instrument that is sensitive to the changes that are occurring for the patients in a particular study, that's able to summarize a lot of these potential effects in a single measure. The key is to make sure that the quality of life measure is at least somewhat sensitive, and no quality of life measure is going to be fully sensitive to all these possible changes, or certainly not as sensitive as a disease-specific measure would be. But to think about what these different things are. And the NEI-VFQ, so that's a visual function questionnaire, quality of life issues specific to vision. The SF-36 is a standard questionnaire that many people use. It, in fact, I guess I would describe it as mostly about function, some other aspects of quality of life, and the EuroQual, which we use for our health utility calculations, has the advantage of having only 5 questions, but that's an advantage in terms of respondent burden. It's a disadvantage in terms of being particularly sensitive to things in this study, and we'll talk about that a little bit more later on. This just gives an idea of the data collection for the different types of instruments, and again, we're very interested in the quality of life measures for this particular application. And then our sample size, 250 participants, 125 per group. You can see the power there and the detectable difference in terms of the changes in the number of letters or the lines based on the ETDRS. And this just shows where our clinical centers were. As you can see, not only spread all across the United States, but also one in Australia and one in the UK. There's the list of the centers and a few other facts about the trial. Okay, so that's the background. So we have this notion that we want to be able to make a recommendation to policymakers. And in this case, the recommendation may have a very high upfront cost. Recommending an implant therapy that costs a couple of tens of thousands of dollars is much different than a treatment which might cost just a couple of $1,000s or several $1,000s over the entire first year and take numerous years to accumulate costs up to $20,000. So this is a really big deal, and we might want to know just how much, if at all, does the implant improve quality of life or others of the functional outcomes in order to say whether it would be worth making a recommendation. So first, some basic effectiveness results. This is just some baseline characteristics. You can see that the mean age was in the mid-40s. Majority women. Duration of uveitis was between 3.5 to 4 years. And then you can see the other characteristics going down the list. So specific aim 1, compare visual outcomes. Again, I'm just going to highlight each of these so we can get to the cost effectiveness outcomes. But you can see that at 24 months, looking at the analysis by eye, you see some changes in both the implant and the systemic group, but not statistically significant difference. And if you look only at the better eye, you also see some changes, but not a statistically significant difference. So in terms of one of our basic measures of one of the most important and most direct clinical outcomes, visual acuity, the two treatments, certainly there is a bigger change on the implant side, but again, the difference is not statistically significant. We can also look at other aspects in terms of the efficacy of the two treatments for inflammation control and preventing structural complications. Here we do see some differences in terms of the uveitis activity, lower amounts of activity among the implant group, or a bigger change in the implant group. And this is showing other characteristics of outcomes. Less vitreous haze for the systemic group. Similar amounts, although clearly the implant is lower, for macular edema. Almost statistically significant difference there. And then moving on to other side effects, again, to sort of lay the groundwork for why the quality of life measure is going to be interesting. We can see that there are some differences here as well in terms of adverse ocular outcomes. A few more tables of adverse intraocular pressure, glaucoma, cataracts. We see differences throughout. And then other complications from the corticosteroids. And then the immunosuppression complications as well. Not a lot statistically significant going on there. And then full-level adverse systemic outcomes, looking at hospitalization rates and looking at infections requiring prescriptions as well. And the infections requiring prescriptions, there was a statistically significant risk ratio. Changes in weight were one other thing that we looked at. Finally, for quality of life, and again, this is getting us to the point now where it's interesting as to why we might want to do a cost-effectiveness study. So here is from the SF-36. You can see mental component scores and physical component scores, which are the standard ways of aggregating the dimensions within the SF-36. You can see, looking at the changes, there are positive changes for the implant group and negative changes for the systemic group at 6, 12, and 24 months. For the mental component score, we see a relatively similar breakdown for the physical component score, and in many of the cases, the p-values are less than 0.05 for these comparisons. Now, if we look at health utility, we see that there's not nearly as much change going on. The health utility, the 5 questions at the bottom are showing us information about the aggregation of the responses to the 5 questions. The 5 questions ask about pain, anxiety, your ability to do usual activities, your mobility level, and your ability to take care of self-care activities or activities of daily living. So there's only 5 questions. There's only 3 levels for each. As you can see, fairly high levels, 0.81 and 0.83 out of a total of 1. At the start of the study, so that's a fairly high amount, not a whole lot of room for improvement. And you can see that the improvements are small, although there are plenty of cost-effectiveness studies out there where even improvements of that small an amount lead to treatments being considered cost-effective. And you can see the difference in the trajectory between the implant group out to 24 months and the systemic group out to 24 months, with small improvements in the implant and small declines in the systemic group. The EQ-VAS is that in addition to these 5 questions where there's a pre-existing algorithm for scoring the results of the 5 responses, people are also asked to put on a visual analog scale, how would you rate your health today on a scale of 0 to 100, where 100 is perfect health and 0 is the worst health state you could possibly imagine. A little bit subjective for the bottom end of that scale, obviously, in terms of each of us might be able to imagine a different worst health state. But as you can see, the scores were a little bit lower on a 0 to 100 scale, sort of proportionally, than on the 0 to 1 scale for the EQ-5D. And we still see the similar pattern of small improvements when it comes to changes for the implant group and small declines when it comes to changes for the systemic group, with some of them being at p-values of less than 0.05. And then for the vision-related quality of life, using the VFQ-25, again, we see improvements in both groups this time, but the improvements for the implant group tend to be a little bit larger. So despite the increased cost, despite the similarity of the changes in visual acuity, or at least the lack of statistically significant difference across many of those, we do see differences in changes for quality of life. So for some cost-effectiveness results, here's some cost information. And again, there's a longer table that this goes with, but trying to show all of the rows that we had on the table wouldn't have been readable by anybody in the room other than me, perhaps. But I just wanted to give you a feel for what the differences are as we look at these 2 treatments. So you can see that even in the first 3 months, the systemic treatment is only accumulating about $3,200 worth of cost on average. And we have the confidence intervals there as well. But the implant accumulated over, almost $37,000 of cost in the first 3 months. That's a big deal, and it's a big difference. And what you can see then is over the remainder of the first year, you have decreasing cost for the implant group in the next 3 months, and then sort of looks like they are going to stabilize in the low 2,000s per quarter, whereas for the systemic treatment, you go up and you move towards $4,000 per quarter. And so again, you can imagine that if you follow these two trajectories long enough, they're certainly going to approach a smaller cost difference over time, and it's possible that they would in fact equal out over time. So here are some preliminary results that we have that were presented at our last data safety and monitoring meeting. We have an implant average over the years of 61,000 and systemic average over the years of only 45,700. Okay, so even if you follow them long enough, it gets a lot closer, but it doesn't even out. That's for the bilateral patients. The unilateral patients get much closer to evening out over the time, largely because for the bilateral, you don't have to double the amount of the systemic therapy, but you do have to do 2 implants, and each of them has a similar cost. This is quality of life information. I thought I had it a little bit neater than that. Sorry when I laid this out. The key here, focus on the means. The confidence intervals simply show whether or not the mean is different from 0, and you can see that in most cases the confidence intervals do span 0 rather than being different from. But again, you can see the changes from baseline. The implant group is positive or 0, very small but positive or 0, where the systemic group in each case is negative, and you can then see the confidence intervals that go with it. Again, giving you a feel for the information. And if you accumulate over even longer than 1 year, these small positive changes on the side of the implant therapy and small negative changes on the side of the systemic therapy, then the difference in that area under the curve will grow over time. And that's one of the reasons that we're interested in measuring this, perhaps not just for the 2 years of our study, but trying to project longer, at least for the length of the expected functionality of the implant, so that we can make a fair assessment of the gains for the duration of the implant's therapeutic effectiveness. So preliminary 3-year results, the bilateral results, the implant was favored by 7/100ths of a quality. Okay, that might not seem like very much, but again, there are studies in the literature where they report differences that small over even longer periods of time. And then the unilateral was favored by a larger amount, which may be reflective of either the treatment being more effective for the unilateral patients, or perhaps treatment being effective for only one eye, even if you have the implant for unilateral patients. A whole variety of things that might be going on. There might be other systemic things that the bilateral patients are experiencing that unilateral patients are not. But it is a notable difference in the magnitude of the quality gains for the implant between the unilateral group and the bilateral group. Incremental cost effectiveness ratios. The bilateral, given its very high cost difference, even out at 3 years, is over $200,000 per quality adjusted life year gained, whereas the unilateral is less than or just about $40,000 per quality adjusted life year gained. And so that unilateral would be considered reasonable. The bilateral would be considered kind of expensive based on what decisions that are made about other treatments. Now, one of the things that people ask is, okay, so you've got these confidence intervals for your cost measures, and you've got confidence intervals for your quality of life measures, and you can certainly construct confidence intervals for quality adjusted life years, not just for the point in time quality of life measures, and confidence intervals for your cost over whatever time period you want to measure them. But how do you describe the uncertainty about the ratio itself? Because now you've got a difference in the numerator and a difference in the denominator. And even if the difference in the numerator was distributed normally and the difference in the denominator was distributed normally, once you get to a ratio, there's no particular distribution that fits that. And so what we did, which is what is commonly done, is a bootstrapping effort. And it was not a small undertaking. Fortunately, I just had to look at the results and had the expertise of others to do the programming. But the key is each of those dots in this graph. So the darker dot is the point estimate. Okay, so the mean difference in cost and the mean difference in quality adjusted life years for bilateral patients. Every other one of those dots is the result of a bootstrapping replication. So you draw with replacement, you do all of the calculations. And, we did calculations using GEE to get the change from baseline and comparing the change from baseline. And we did all the cost work over time. And we summarized the data over the multiple years. We had the inflation adjustments for the cost data. When you summarize cost data over multiple years, you have to think to yourself, okay, are the costs in the third year given the same weight as the cost in the second year, given the same weight as the cost in the first year? And there's some standard sort of financial transformations that we do between years looking into the future, as well as bringing costs from the past up to the present. So all of that goes on each time. It's a lot of work each time, but we did 5,000 replications. And then we look at the distribution. And what this distribution is showing is that there are some replications where we actually don't gain any qualities for the implant. There's actually fewer qualities, but it's still more costly. So it's not that we have fewer qualities and we'd be saving money, which might be viewed as okay if we saved enough money, even if we lost a little bit of health, but it's more qualities and not saving money and spending more money. So that's not a good sign for the implant, for the bilateral patients anyway. We have one or two down here where it actually costs less and led to more qualities. And then we're interested in what the shape of this is. So there's two things that we notice. One, it's very much just a circle with scatter, so there's no particular correlation between the changes in the quality adjusted life years and the changes in cost. Sometimes there's a fairly strong correlation between the two. Living longer might cost more. Living a higher quality of life might cost less. So it could go either direction in terms of how that cloud is slanted, but this cloud is just broadly distributed. The other thing that's interesting to ask is if we drew lines that represented different ratios for dollars per quality gained, what proportion of those replications would suggest that it's less than $50,000 per quality? And what proportion of those replications would suggest that it's less than $100,000 per quality? And I've got a slide just two later that will help to illustrate that. For unilateral uncertainty, it does have the same characteristic of being just sort of broadly distributed without any particular correlation. But what's much different is we now have a substantial number of replications that suggest the implant might actually be less expensive and more effective. We have a few that suggest less expensive and less effective. Again, we have to ask, would we be willing to go this direction if we saved enough money? Several that are, and it's just a smaller proportion. I mean, there's a fair number here, but it's a small number proportionally that are more expensive and less effective, and then a much bigger number in this area over here. So how do we summarize that? We summarize that with something that we call a cost-effectiveness acceptability curve. And one way of reading this, it's sort of like a cumulative density function where it gives us the probability that we would consider the alternative, implants in this case, to be cost-effective given varying levels of the value of a quality adjusted life year. Is a quality adjusted life year worth $200,000, $1 million, or some smaller amounts that we have here? And what's interesting, you can see that the median for the bilateral suggests just about $43,000. The median for the, that was the median for the unilateral. The median for the bilateral is out at $210,000 or so. But what's interesting is the policymaker might want to say, well, what's the probability that the implant has a cost-effectiveness ratio of less than $100,000 for unilateral patients? It's up here around 85%. What we don't know is whether policymakers think that, do you need 85% certainty to make policy? Do you need 95% certainty? Would even better than 50% be enough to make policy based on? It's just a way of helping to inform the policymaker about how much certainty there is that the cost effectiveness is at a particular level. Just a little bit more on the 3-year data. We have the potential, we have both data at every 3-month and every 6-month, and it's just, again, giving some additional insights into how these data are broken down over time. So now I want to talk about some of the challenges that we faced. You might already be thinking this is, a huge undertaking, and the simple answer to that would be yes. But I want to sort of illustrate things. So the first thing is choosing the right time frame. Okay, so if you go to scientific recommendations about how to do cost-effectiveness studies, and in the United States, there was a group called the Panel on Cost-Effectiveness in Health and Medicine that worked in the mid-1990s and then came out with a set of recommendations in the fall of 1996. They suggested, if you can, every cost-effectiveness analysis should, follow people for their lifetime. That's nice in theory if you have enough supporting data to do that. But sometimes the relevant decision-making period is much shorter. So we could say we're only going to do it for the time of the main study, out to sort of the 2 years. For the lifetime of the implant, which is sort of out to 3 years, although there's variety and heterogeneity in how long the implants continue to be effective, or the lifetime of the patient, or something else entirely. But we have to make a decision about that. We have to plan for collecting data within the study to support the decision, and we have to have some awareness of whether there are natural history or other data outside the study that we could use to supplement our data inside the study to build a model then that would describe the cost effectiveness over some time period other than the time period that we've directly collected data for. So that was one challenge, and even going back and forth between trying to match main results at 2 years and having data to do 3 years and which one is more relevant for future clinical decision making was an interesting issue. Unilateral versus bilateral. And this is something that surprisingly hasn't really been addressed very much within the cost effectiveness literature in eye care. Okay, there are lots of conditions that can be either unilateral or bilateral. But you don't see a whole lot of studies that take the time to distinguish between these two. We thought it was such a huge issue, given the cost for each eye, that it would have made no sense to talk about the results in aggregate for unilateral and bilateral together. And so, we made a distinct decision. But I had to go through the literature, and I scoured the literature and asked other people I know who do cost effectiveness in eye care, and none of us could come up with any really good examples, or a very limited number of really good examples in other parts of the eye care world where people had really taken the time to look at unilateral versus bilateral, with one exception. Sometimes cataract surgery. Should you do it simultaneously? Should you wait until one is done? That's something people have looked at a little bit. But there are both big differences in cost, and as you could see from that summary of the QALYs gained for implant versus systemic, unilateral versus bilateral, some really big differences there. Now, we could do some analyses per eye rather than per person, but we can't really measure quality of life per eye. And so that's one of the reasons that we had to focus on the person as the unit of measurement, and for cost as well, and then think about how we would describe the results. And again, in our case, we thought it was most important to present the unilateral and bilateral separately. Obviously, this wouldn't apply to all organ systems in people, but it is something when you're working in eye care, it's an extra complication to think about in terms of describing the cost effectiveness. Now, the outcome. If we were going to do a cost effectiveness study rather than a cost utility study, what would be the most important outcome? Okay, again, is it changes in visual acuity? Is it months or weeks of activity levels for the uveitis? And the fact is, there are a fair number of different possible outcomes that could be chosen. There was the main outcome as well as all the side effects, as I illustrated earlier. And so it's something that needs to be given very careful consideration, because while talking about dollars spent per quality adjusted life year gained allows us to put this in the context of a broad existing literature where things are talked about in dollars per quality, decision makers, clinicians, people making recommendations, they may or may not really have a good sense of what qualities are doing, and they may in fact be more interested in knowing, well, how much do we have to spend to avoid a month of uveitis activity? Which is interesting, but then we have to decide in the same way that at some broad level, if we're talking about dollars per quality, we have to decide what's a quality worth. Is it, again, $50,000, $100,000, some other amount? We would have to decide, well, what's it worth for a month of uveitis activity avoided? Or what's it worth for a 1 line or 1.5 line improvement based on the ETDRS measure of visual acuity? And we don't have standards out there. Now, we can sort of intuit, perhaps, whether it's worthwhile, but again, that's something that we have to give consideration to. Health utility, which measure and how sensitive? I mentioned some of the advantage of the URAQUAL, only 5 questions. It asks only about today, so we don't really have any recall bias, whereas with the SF36, that asks about the last 4 weeks. So if you had some symptomatic days and some asymptomatic days, or some more symptomatic days and less symptomatic days over a 4-week period, how would you give a single answer? You know, think about any condition you've ever had where there are symptomatic and asymptomatic days. If somebody asked you about the immediate 4 weeks preceding that, it could be really hard to give a single answer to a quality of life question. The other advantage to the URAQUAL is it's simple, very low burden to the respondent. It's quick, both for the respondent and in terms of code being readily available to score it. The Agency for Healthcare Research and Quality in particular funded an effort to score the URAQUAL using U.S. population. So they have the scoring code in SPSS, SAS, and STATA online to be downloaded for free. The instrument is free, and the coding is free. So that's a lot of advantages. The disadvantage has a ceiling effect, again, at baseline. Many of our study subjects indicated no problems on the 5 domains that I described, and it wasn't hugely sensitive in terms of capturing big change. Now, there are some other health utility instruments out there that have vision as one of the domains. Not free, much more complicated scoring system. And I think it's an open question, even among people who do cost effectiveness in eye care. Do we really want to penalize everyone the same amount for problems seeing newsprint or problems seeing faces across the street? Or are we really more interested in whether or not it makes the person anxious and how it affects their subjective interpretation of their functioning, rather than just saying everybody who can't read newsprint has exactly the same change in quality of life? It's an ongoing question among people who do this work in eye care. Cost of treatment. If the study had been at a single center, which we probably never would have been able to get enough patients for, but if the study had been at a single center, we might have been possible then to use the center's data for billing or local insurers' data. But when you have multiple centers in multiple states and countries, you have a much tougher job. And so we had to decide what level of detail we were going to ask about. So prices of pharmaceuticals, there's a book that's available both in electronic format and hard copy called the Red Book of Drug Topics that provides the average wholesale price. You go back 10 years, this is what everybody used in cost-effectiveness studies. More recently, particularly with Medicare Part D and Medicare covering pharmaceutical products, we find there are a lot of insurers paying negotiated rates that are below the published average wholesale price. So this is no longer something, we used it and we came up with some adjustments to try to capture how it's been reported as being different. But if you can get data on the average sale price rather than the average wholesale price, when the average sale price is actually likely to be lower than the published average wholesale price, that's kind of important. The price of procedures. Well, again, it would be great if we knew what each procedure actually cost in each hospital. Really tough data to get. So we used Medicare reimbursement rates. Well, first of all, if all you have is a brief description on a survey form, you have to figure out what is the appropriate CPT or current procedure terminology code, or what is the appropriate hospital admission code, and then go to the Medicare charts and find the appropriate level of reimbursement for that. And there are both professional fees and facility fees, and you have to make sure that all the right things are included. It's great if somebody had reported in the literature, here's what it costs to treat uveitis for a year, but there really, with this disease anyway, aren't a whole lot of studies out there preceding ours to help us along the way with that. Quantities of services and pharmaceutical products. Again, what is the service? And for the pharmaceutical product, if all we know is they were taking the product, well, how much of it did they take? How many prescriptions did they get? Is it chronic or acute? If it's an antibiotic, hopefully they're not taking that chronically. And so we had to come up with rules. And these rules took a year? Maybe more than a year, for us to figure out exactly how to lay it out and how to do it. It's not a small matter. And then, again, for number of pharmaceuticals, if you wanted to make it a little bit easier, you could try to ask only for those that are related, but that's a little bit subjective in terms of what's related as opposed to asking for all. When you ask for all, you get quite a lot, some of which may be more relevant than others. And we actually developed a threshold. We said, if only one study subject in the entire study reported something, then we weren't going to go to the trouble of trying to cost that out. Finally, bootstrapping. I mean, bootstrapping, there are some standard, software for it these days, not standard for the cost effectiveness calculation. But we're not just bootstrapping a mean here. This is a big deal. Bootstrapping multiple things along the way to create each of those dots on that chart. So you figure to get each one of those dots, all of those challenges had to be answered. And then we had to bootstrap for each time going through. Just a few other things about alternatives. Now, we could conduct a modeling exercise rather than doing a randomized controlled trial to try to address the same question, but usually we're relying on somebody else having done the randomized trial earlier, and then we're just going to apply the economic evaluation to it. Even if you do that, you still have to make judgment calls. So the judgment calls and decisions about how to price things out and how to make assumptions along the way don't go away just because you do a modeling exercise. It's just a different set of assumptions that we have to make. And then finally, so we've been talking about cost effectiveness and cost utility. We could have done other analyses. We could have done a cost consequence analysis. So this would be simply saying all those charts that we had with the visual acuity changes and the quality of life changes and the side effect profile changes, we could just say, here's the difference in the treatment outcomes. Here's the difference in the cost. You who make the guidelines or the reimbursement decisions, you figure out whether the extra cost of the implant is worthwhile or not. Now, one of the reasons that we do cost utility analysis, for example, is to help the decision maker come to that conclusion by guiding them in terms of the relative weight of the different outcomes rather than leaving it to the subjective decision making for the decision maker. We could also try to do a cost-benefit analysis, but that's even harder in many ways than cost utility because each of those side effect outcomes and each of those outcomes about quality of life, we then have to come up with a way that we would all agree on to put a dollar value on those changes. And I can assure you, while putting a dollar value on medical care procedures is not simple, there are at least things that we can point to, like average sale prices and average Medicare reimbursement rates and things like that. Whereas putting a dollar value on quality of life changes, there are standard procedures for doing it, but those are even more contentious than measuring quality of life using health utility. So that sort of, again, provides the picture of a study that was, where cost effectiveness was one of the main goals. So we took all of the steps along the way to make it as high quality as possible. But I don't think that any of us appreciated when we started just how complex some of these decisions were going to be, how much time and effort it was going to take to map from the quantity data that we collected to something that we could actually use for a cost effectiveness analysis and then get the prices, do the analysis, describe the uncertainty about the ratio, and come to a point where we are moderately comfortable at this point, still working out some final details, but moderately comfortable describing the relative cost effectiveness, although those results are in fact preliminary, but the relative cost effectiveness of the two different treatments. So we have a few minutes for questions. Yes?
I had a couple of questions. Wow. But do you take into account in your recommendations that if this is more widely adopted, that the cost will come down of the implant?
Well, I mean, part of it is whether that's actually going to happen. So certainly the cost of an individual procedure does tend to come down. If we look at pharmaceuticals, things come off patent, things get less expensive. People get better at doing it. So maybe it's less costly to perform it. However, particularly if we're using Medicare reimbursement rates, there's no guarantee those would go down. And as the technology improves, one thing medical care device manufacturers have a tendency to do is they don't just leave the device in a single format. They improve it. And so it may be the case that if the technology were static, the price may come down. But in many cases, the technology continues to improve. The price in the end stays about the same or even continues to go up. And so while we could do some projections and say, well, what if the price came down by a certain amount? How would that change our recommendation or our conclusion? Most of that is just speculative. And so we leave that in the realm of what we call sensitivity analysis or what-if analysis, where we try to do a few extra analyses, changing some of our assumptions to help guide the decision maker, again, with possible changes like the one you suggested.
And my second question is, when you were designing it in the beginning, did patients give you input on what outcomes were important to them?
I don't think so in general, and certainly not with respect to the quality of life measures.
No, I wish we had more of that information, but next time.
There you go. Yes.
So I have a question about the power for the cost effectiveness or cost utility analysis. So I think you have like 3 different instruments in there with the variable sensitivity to the thing you're trying to measure. So with the sample size in mass, what is the power that you will be able to really detect the difference? Perhaps detecting the difference is not the whole purpose of it. You are as interested as the change from baseline in each individual.
So I can't think of any cost-effectiveness study that was tacked onto a randomized trial where people powered the study based on the cost-effectiveness study. And the main reason being that costs are so variable, typically much more variable than any of the clinical or quality of life measures, that the sample size you would need would just be astronomical. While there are some people who have begun to do power calculations, it's usually only by simulation that you do those calculations, and certainly that wasn't something that we did for this particular study. But it's a good question, and what you tend to do then is you tend to say, okay, given this expected difference in the qualities and this expected difference in the costs and what that would lead to for an expected ratio, and again, sort of almost simulating the bootstrap, and then seeing what it says about, detecting what percentage of the replications would be below a particular threshold. So it's not a terribly well-developed area yet. Again, largely because there aren't a whole lot of studies where people have the resources even to tack on something like this to a randomized trial.
But it seems to me like be able to find the difference between the 2 treatments is perhaps not the most important thing. I don't know, I feel like the impression I have based on your talk is, just understand the cost effectiveness for each treatment is as important as the difference.
Well, I think that within most of these studies, the difference in the effectiveness of the treatment is still the main motivator for the study. And so, but it's not the only motivator. And I guess the key then is, will one of 2 things ever occur? Will policy be made enough based on the cost effectiveness results, which isn't happening very much right now. But if policy were sufficiently dependent on the cost effectiveness results, and we could somehow get the cost to be a little more precise of a measure, then we might be willing to start powering some of the studies specifically for cost effectiveness. But I think as long as the cost effectiveness results are mostly seen as an informative extra rather than the main purpose of the study, and we recognize the fact that the costs continue to be highly variable, that we're not going to get very far trying to power it based on the cost effectiveness. It's a great question, but I just don't see that happening in the very near future.